Appreciate everybody coming. We have an important topic today. Those of you that do critical care realize that this is a very hot topic which changes rapidly. Dr. Grier is going to give us an update on what the thought process about sepsis is in this day and age.
Sounds good. Thanks for coming, guys. We appreciate it. We have quite a mixed bag. I don't think I've lectured to this many people in this room. Med students usually get about 10 or 15, so that's pretty cool. So let's get started. I couldn't get my guys to do this, so.
I'm bringing sepsis back. It's vasoactive shock, and that's a fact. It makes your BP drop oh so fast. So grab a latte, run the fluid snap. Tube it to the lab. Infected babe, you're in the shock and it's getting great. I start the funding, just don't hope and pray. It's just that sepsis makes me feel this way. Take him to the unit. Breathe in the blue. Meet search criteria. She's tacky 2. Meet search criteria. Temp 102. Meet search criteria. Left shift voodoo. Meet search criteria. Mr. Word biz. Go ahead, get away. Check the UA. For bacteria. Quick chest x-ray. For pneumonia. Give cultures too. For bacteremia. Get your sepsis on. Go ahead, suspect it. Get your sepsis on. Go ahead, detect it. Get your sepsis on. Go ahead, suppress it. Get your sepsis on. Go ahead, correct it. Get your sepsis on. Get your sepsis on. Go ahead, correct it. Get your sepsis on. Get your sepsis on. I'm bringing sepsis back. Those microbes aren't prepared for my attack. Check these broad spectrums I've got on the rack. I narrow therapy by culture track. Give them all a Vosin. Septic bay. 4-liter bolus and you're still the same. I start the pressors through the central vein. I hope your BB starts to make some gain. Get a more perfusion. Breathe in red blue. Meet search criteria. She's tacky 2.
I think you guys got the idea.
102. Meet search criteria.
I think you got the idea. Just something different to get us started with. So, all right, let's talk about sepsis. We've talked about this before. We talk about it every year. And there's a reason why we do it. We do it every year because basically if we don't, we end up with major problems in our patients from both mortality as well as morbidity. So why is it important? Well, we're going to talk about where we started and kind of bring it through a continuum of where we've been to where we are now. We're going to talk about sepsis 3. This is where we've been since 2016. And of course, we're going to throw the early goal-directed therapy controversy in there because even a couple of years later, we're still talking about it. Now, has sepsis been around forever? Oh yeah, it's been around forever. Even Machiavelli, back as far as the 1400s, 1500s, described it. And he says, as the physicians say it happens in hectic fever, that in the beginning of the malady it is easy to cure but difficult to detect. But in the course of time, not having been either detected or treated in the beginning, it becomes easy to detect but difficult to cure. And that's very, very true of sepsis itself. And then a lot of other previous definitions have come out. Hippocrates, Galen, and Pasteur all described sepsis in their own words. And we're still seeing it. And you know, Superman, the Pope, Kermit the Frog all died of strep pneumonia, sepsis, and Patty Duke Austin actually died from intra-abdominal sepsis. So it wasn't really until we started seeing people like this, celebrities, people in the news, that the general population started wanting to know, what is sepsis? You know, where did it come from? You know, why don't we know more about it? And right now, it's the leading cause of death outside of the coronary ICU. It's the 10th leading cause of death overall in the U.S. There's probably, they diagnose or document 750,000 cases of severe sepsis every year. However, if you truly break down your ICD-10 codes and some of your DRGs, the numbers are probably a lot higher. Your mortality rate kind of varies depending upon where you are, where you practice, and the type of patients that you're going to see. If you're living in some place such as Colorado Springs, where you have a very, very healthy, active population, your mortality rates are going to be lower. If you're practicing in inner city Detroit, where you're seeing a bunch of nursing home patients, your numbers are going to be higher. So it really kind of varies from there. But overall, you're probably looking at about 30% mortality, or about 575, 600 deaths per day just from this particular diagnosis. So with all of that going on, one of the things that we started to notice is that people in the 1980s and even the early 1990s, there were a lot of different definitions that were out there. You heard about infection, complicated infection, bacteremia, septicemia, sepsis, septic shock. All these diagnoses were out there, but there weren't any real consensus definitions. I mean, I can tell you that as a fellow, I got so many different phone calls and it was really weird. It's this thing that somebody delivers to you. It's called mail, and they actually bring it to you, and it's paper, and you read it and write on it. But they would ask for surveys of what your particular definitions, what did you think these words meant? And based on all of that, this group of guys got together from the ACCP and FCCM. They got together in 1991, and they looked at all these different definitions and all these different surveys that people had taken over the years. And the idea for this concept was that everybody could be on the same page. Everybody would know what the definition of infection was, or SIRS, or sepsis, severe sepsis, septic shock, MODS. Everybody would be on the same page. So that when we talk to each other, it'd be a lot like our oncology colleagues, that when they talk to each other, they know what the T&M means. If you tell somebody has this type of cancer and you go through their staging classification, everybody knows exactly what you're talking about. When we talked about sepsis, severe sepsis, septic shock, or MODS years ago, everybody wasn't on the same page. Now, with these consensus definitions that came out in 1992 in CHEST, everybody was on the same page. I told you you'd probably get a trauma stat in the middle of this. Happens every year. So they published that, and everybody's very comfortable with it. They're like, awesome. We could talk to each other. We're on the same page. When I call you to discuss a patient, everybody understood what everybody else was talking about. And then in 2001, Society of Critical Care Medicine and ACCP said, we need to get together and re-look at all these definitions. And they invited colleagues from the European Society of Critical Care, ATS, and the Surgical Society to come together and say, okay, we have these 6 definitions. Do we want to keep them? Do we want to change them? What do we want to do? So that in 2003, they actually went ahead and published what you see in the middle column right there. And that they didn't change the definitions. All 6 of the definitions stayed the same, but they kind of expanded on what they defined in the previous 10 years. So that we're still talking the same language. We're just expanding and being more, more descriptive of what we're talking about. Now from there, we talked about infection. And remember that infection can be bacterial, it could be fungal, it could be viral, it could be parasitic. When we talk about sepsis and we think about sepsis, we always think bacterial, don't we? But keep in mind, it can be any sort of organism that can cause an infectious process. SIRS, Systemic Inflammatory Response Syndrome, as you guys are well aware, has 4 components. Alterations in temperature, tachycardia, which for some reason they described as greater than 90 beats per minute. They obviously hadn't been in pathophysiology class in med school for a while. Problems with respiratory rate for tachypnea, and alterations in white blood cell count. Now, one of the things we're going to talk about later is the sensitivity and specificity of SIRS, in that if you went outside and I asked you today, go run around the building twice and come back in here, just about everybody would meet SIRS criteria. It's hot out, so your temperature is going to be up. You're going to be breathing fast, your heart rate's going to go up, and you're probably going to demarginate some white cells because you just stressed yourself in a stressful situation. Are you septic? No, you're not. So there's questions that come up with SIRS, but for sepsis 1 and sepsis 2, SIRS played a major role, to the point where that if you looked at the definition of sepsis, it actually became 2 or more SIRS criteria with a confirmed or presumed infectious component. And then severe sepsis was sepsis with an organ dysfunction And if that organ dysfunction happened to be refractory hypotension or shock, it became septic shock. And those were the definitions, those were the continuum for both sepsis 1 and sepsis 2. Now we all know that there are 7 organ failures, right? Not just the big ones, such as cardiovascular, respiratory, and renal. There's actually 7, right? Not just 3 that everybody talk about. We all know about cardiovascular, hypotension, tachycardia, whether or not they need vasopressors or not. We know about respiratory, patients that are tachypnic, hypoxic, hypercapnic, patients that need to be put on either non-invasive or invasive mechanical ventilation. And renal, where they have decreased urinary output less than 0.5 cc's per kilo per minute, per hour, versus increasing your creatinine by 50%. But there's also 4 others. Neurologic, altered levels of consciousness, decreased GCS. Hepatic, looking at increase in your liver functions greater than 2 times normal. And the 2 on the bottom, to me, are probably, I hate to say the most important, but they really are. When you start looking at lactate, you start looking at metabolic failure, metabolic organ failure. Is the patient aerobic or anaerobic? If they're anaerobic and hypoperfused, their lactate is going to be elevated. That is an organ dysfunction. And you come over here and you look at hematologic. For years, when I was younger, we used to say patients had septic shock with or without DIC. Well, DIC is a component of the hematologic organ failure. So therefore, when you look at that, do they have a component of DIC? Are they thrombocytopenic? One of the most important components of organ dysfunction in the septic patient is what is their platelet count? Are they thrombocytopenic? Are they developing thrombocytopenia? And a prognosticator is how low are their platelets and how fast do they drop. So to me, even though we have 7 organs, these 2, to me, are probably the most important when you look at prognostication and how patients are going to do. But there have been a lot of studies that have come out, both Angus and Vinsalt, both published articles early on saying that as the number of organs fail, your mortality rate goes up. The same thing got repeated by Jean-Louis Vinsalt and Sacker a couple of years ago. And what they showed is that patients who have sepsis have organ dysfunction. The majority of these people have 0, 1, and maybe a few have 2 organs down. But as you look at the number of organs that are failing, the number of patients that have them are lower, but their mortality rate goes up significantly. And why is this important? It's important because you as a clinician need to know, flat out, how sick is my patient? How aggressive do I need to be? How fast do I need to respond? If you've got a 19-year-old that comes in with pyelonephritis and has 3 organ systems down, you need to go fast. You need to throw everything you can at them and work quickly. You have a 90-year-old that comes in who's been bedbound in a nursing home for the last 20 years and has 3 organ systems down. You're going to have a different conversation with the family. The mortality rate is going to be 70, 80, 90% in each of those individuals, but the likelihood of survival is going to be different, so it helps you as a clinician know how sick your patient is and be able to react in an appropriate way. And by knowing that, you're going to know how to deal with those particular patients in each particular situation. Make sure everybody's awake. Now, when we look at the pathophysiology of sepsis is very complicated. I could put up slide after slide that shows a bunch of words that I can't pronounce, that you guys can't read from back there, or we can summarize it. And when you look at the pathophysiology, you're really looking at a couple of things. One is microvascular dysfunction. You're going to see increase in inflammation, increase in coagulation, and decrease in fibrinolysis. In so doing, you will start to see hypoperfusion and hypoxemia to the tissues. And that's going to come from the fact that you're going to have microvascular thrombosis from those coagulopathies with those little microthrombi that are going to start blocking capillaries, also causing endothelial dysfunction, leading to tissue damage and global tissue hypoxia. And this is important because when you look at a patient who comes in septic, you're thinking to yourself, how did somebody with a UTI, somebody with a tooth abscess, end up with multi-organ failure, on event, 3 vasopressors, dialysis, when they've got a urinary tract infection? How did that happen? Well, how it happens is that sepsis is a disease of the microcirculation. Everything I just showed you on the previous slide affects the microcirculation, and it affects it not just in that organ system, but throughout the body. And as that happens, as you can see listed on this particular slide, all of these other things are occurring. So therefore, you may start with a simple UTI, and end up with a dead patient. Why? Because of what's going on in the microcirculation. And because of that, because of the fact that this is a systemic disease process and it can affect patients significantly, not only are we good with definitions, we can all talk to each other in definitions, but those particular sepsis 1 and sepsis 2 didn't help us with how do we treat our patients. They didn't really help us much with prognostication except for organ dysfunction. So in 2004, a group of very, very smart people, some of which I know, some of which I do not, got together and said, let's come up with some sort of management guidelines that people throughout the world can follow. So not only are we talking on the same page when we talk to definitions, we're also talking to each other on the same page on how to treat those patients. And they weren't necessarily throwing this information at people at academic centers who do this all the time, but it was really out there to help, you know, Dr. Jones, Dr. Smith, these guys out in the community. If you're Dr. Jones or Smith, I apologize. No, I really don't. But if you're out there in the community, you're not dealing with the disease process like this every day, then it was helpful for them to be able to look and see what we should be doing. And they pulled all the evidence that they could find. They pulled all the articles they could find, anything that they could find on sepsis, severe sepsis, septic shock, pulled all of it, and they took a look at all of these, and they based everything, as you know, they graded them on hierarchy of evidence and grading of recommendation. And they got this. And from there, they took each of these particular treatment modalities and put them into the infamous bundles that we all know and hate. But they're there, and they were there for a reason, because it gave us the opportunity to see what should we be doing for the first 6 hours, what should we be doing for the first 24 hours. And it gave guidance. And people were able to start following, and if they had a patient that met criteria for severe sepsis, they knew exactly what they should be doing from point A to point B to point C. And they just kept going down the particular bundles. And in 2004, this was acceptable. There was no argument, there were no issues, there was nobody saying, well, I don't agree with this, that, or the other. People accepted it, they looked at the literature, and they started treating their patients accordingly. Now, in so doing, 4 years later, they got back together, added a few people, got rid of a few people, people do come and go, and re-looked at what they had found for the first set of articles, pulled what's happened since that time, and they kind of revamped the bundles. They renamed the 6-hour bundle the resuscitation bundle, and they renamed the management bundle for the 24-hour bundle. They made a few changes in this, and then you started seeing lactate coming first, but everything really in this particular bundle, nobody really questioned. There wasn't a lot of controversy when it came to what to do with these things. People were accepting, people were initiating, and doing what they were supposed to do pretty much across the board. When you looked at the management bundle, you started to see some questions. People started to push back a little bit. And there's a lot of controversy over all 4 of these particular requirements. Drotrecogin alpha, or activated protein C, was based on one study, one evidence-based study that came out, and all of a sudden, when other studies started to show a difference, this particular agent itself, right here, although it was in the bundle in 2008, by 2009, 2010 was gone. FDA wouldn't even allow you to use it anymore. Lilly stopped making it. When you took a look at glucose control, tight glycemic control, where do you practice? Do you practice in the surgical ICU? Because the first study that came out looked at the improvement in survival using tight glycemic control in the surgical ICU. Well, when the study was repeated in the medical ICU, all of a sudden those great numbers of survival changed and they dissipated. So people started arguing back and forth going, well, it doesn't work for my patient population, why should we be doing it? My recommendation with this particular variable is read the study closely. In the DeBacher studies in the studies for this, what you'll find is, yes, you're absolutely right. If you look at it overall, there is no difference in mortality when you look at tight glycemic control overall. But if you look at the medical ICU patients, after 72 hours with tight glycemic control, you see a difference in mortality, time on the vent, need for CRT, infections, and overall length of stay. So the longer the patient stayed in the unit, the more benefit they derived from tight glycemic control. Whereas when you looked at the studies for the surgical patients, Most of those patients were in and out of the ICU, cardiovascular, stuff like that, in and out of the ICU within 24 to 48 hours. A whole different patient population. So you have to actually read these studies very, very closely. Don't just read the abstract. Read the abstract to find out if you're interested in the study, and then read the entire article to see what it actually tells you, whether that's going to change how you practice medicine. Low-dose steroids. Oh my God, read 100 articles, you're going to get 50 different opinions going back and forth. And as for tidal volume, low tidal volumes, no one will argue that. Absolutely no one will argue that lower tidal volumes are better than higher tidal volumes. But this particular study that came out in 2000 doesn't help you a bit on how to actually manage those patients. What mode should you use? So yeah, lower tidal volumes are great, but there's so much controversy in all of those in the management bundle that you really have to read the articles closely and adapt that to your clinical practice for your particular patient. Whereas when you look at the resuscitation bundle, you can adapt that to just about most patients in most situations for sepsis. So 2008, we move ahead. 2012, you guys detecting a theme yet? Every 4 years, they get together and they review everything. Come 2012, again, they really were focusing on severe sepsis. And they were looking at the same thing. They're looking at organ dysfunction. And the same thing that we talked about in the previous slide, they just worded it a little bit differently. The importance of recognizing which organs are affected, how many, and what do we need to do to correct those things to improve the outcome of our patients. And the big thing that they did in this particular year was that they broke up the 6-hour bundle. They had things that they wanted done within the first 3 hours, and then they had to be completed within 6 hours. And what was extremely important and really kind of made me feel good about it was, again, we're looking at lactate. Lactate is so important. It really, truly is. Blood cultures, looking for source control, broad-spectrum antibiotics, giving 30 cc's per kilo of crystalloid. There was also a caveat in there that you can use colloids as well for patients with hypotension or hypoperfusion with elevated lactates. After you do that, if the patient's still hypoperfused, still has an elevated lactate, then you can look at giving vasopressors. You could look at putting some form of device on to measure what your patient's true volume status and perfusion is. Now, for some reason, and I don't know what it is, they will not take CVP off of these bundles. I don't know why. I think it's just because so many people still in the private sector still use CVP. We all know that a CVP of 2 means something, a CVP of 30 means something. You got a patient that's on a vent with a PEEP of 12. I don't know what a CVP of 12 means in that particular patient population. So CVP is very, very, to me, not very useful in the middle numbers in our patients. You can measure SCVO2 as we've advanced from 2012 to 2016. You're starting to see where they're adding the use of minimally invasive and non-invasive technologies. You can use ultrasound to look at IVC. You can use the minimally invasive monitoring, such as a PICO or the FlowTrack or the Cheetah, things like that, to help get your numbers from here. And they end the 6-hour bundle with remeasuring your lactate. And that's extremely, extremely important. And the reason why it's so important is because it goes right back to one of the first things that any of us learned in medical school as a freshman medical student is to look at the Krebs cycle. And what you know, is that in an aerobic mitochondria, you're going to make 38 ATP per cycle. So that mitochondria is sitting there in aerobic metabolism going, bring it on, I got this. Because your supply totally, no matter what's going on, your supply is greater than your demand. However, in your hypoperfused state, and you shift to an anaerobic metabolism, all of a sudden you've got 2 ATP per cycle. And by doing that, all of a sudden your demand is higher than your supply, and you start seeing mitochondrial failure, which leads to cell failure, which leads to death, organ death from there. What do we measure? We measure lactate. What should we measure? We should measure pyruvate, because pyruvate is the ultimate outcome of this particular cycle at that particular point. The problem is that we can't measure pyruvate at the bedside. It's a very unstable assay. You just can't measure it. So we measure its surrogate, lactate. So therefore, the higher the lactate in most situations, not all, there's type 2 lactates out there, You know, if you give somebody Zyvox, they can end up with an elevated lactate. If you end up leaving the tourniquet on the arm for a prolonged period of time, your lactate can go up. But most of the time when you're talking about severe sepsis in this situation, your lactate being up is an indicator of hypoperfusion and therefore anaerobic metabolism. And therefore, that's why we measure it from there. And the higher your lactate, the more acidotic your cell, the more acidotic your cell, the less it is to respond. If you have a patient that you are treating and you think that know that they are volume replete, and you start them on vasoactive medications, whether they're vasopressors, they're inotropes, afterload reducing agents, whatever it is, and it's not working, check a lactate, check a pH. Patients that are acidotic, these drugs will not work in. We had a patient about 2 years ago that came in as a young guy who was in cardiogenic shock. They were pushing everything they could, and this kid is just tanking on them. And I just happened to walk by and notice that the kid's pH was like 6.8 on a blood gas. And I'm like, give some bicarb. And they gave some bicarb, got his pH up, and all of a sudden everything kicked in. So metabolic acidosis is extremely important, so you've got to know what your patient's perfusional status is. You've got to know what their lactate is. Now, are there any studies to back up what I'm telling you? Yeah, Janssen started it back in 2010. He took a look at what we did for early goal-directed therapy, and he measured SCVO2 and lactate. He measured lactate. The lactate was elevated. He used greater than or equal to 3. He broke them down into what's the SCVO2. Remember, the normal SCVO2 is about 70%. And from there, he just followed an algorithm. And if the patient's lactate improved by greater than 20% in 2 hours, then the patient was going in the right direction, and you kept going with your therapeutic intervention. If it didn't, you went back up to the top, and you started all over again. And so doing, what they found was that if you follow the lactates both improved, right? You're treating the patients, the lactates are getting better. And if you look at, they gave fluids, red cells, inotropes, vasodilators, vasopressors, just like an early goal-directed therapy, you follow it down your algorithm, and overall, what he found, there was a 10% improvement in survival just by following lactate and improving lactate. Did it reach total p-value, statistical? No, not quite there, but you know what? It's good enough for me. I mean, if you ask a patient's family, hey, I can do all this and follow lactate and try to normalize my lactate. My p-value wasn't quite 0.05. Is that okay, or you just want me not to do it because we just didn't quite get to statistical significance? I don't know too many families that would say, nah, don't do it. So it's pretty close, but 10% improvement is significant from there. And it holds all the way out to 200 days, the difference between the two. Now, Pushkaritz and his group took a look at whole blood lactate clearance. And this was kind of cool in how they did it. And then if you follow it, lactate normalization in 6 hours, survival was 93%. Those that didn't meet that criteria, survival was only 67%. If you cleared it by 50%, 90, and then 68. And then as you go from there, if you couldn't clear it, mortality went down significantly. So just by following your lactate and clearing your lactate, you improve survival. Why? Because you shift them from anaerobic metabolism to aerobic metabolism. Mitochondria are functional. The cell is functional. The organs will survive. And just a quick follow-up with Huink that just came out in 2016. He actually took a look at all those different parameters, and what he found the best indicators for survival were going to be normalizing the lactate and normalizing the mean arterial pressure. Best survival by doing both of those things. So that's why when we start seeing lactate in 2012, it's so important to start following those things. Well, we talk about fluid, and we talk about fluid a lot in critical care. Now, we always ask every day, for those of you that are rounding with me, we ask every day, what are their eyes and nose? What does their IBC look like? How much fluid do they get? How much fluid do they need? Why is that important? Well, it's important because as you look, and this doesn't show very well, the lower the CVP, the better the patient's survival. Put it another way, on a John Lewis study, patients who have a positive fluid balance have a worse outcome than patients who have a negative fluid balance. You don't want to volume overload your patients. Why? Because you get organ edema. You know, you don't just get pulmonary edema. You don't just get peripheral edema. You get organ edema through all the organs. The heart can't pump as well. because your myocardial cells are edematous. The same thing is true throughout the entire body. And we always take a look and we always see the Starling curve. And we always see that the upward stroke of the curve showing a patient that's preload responsive. Then we get to the plateau phase, which they're preload unresponsive. But what we never ever see is this part of the curve, where if you continue to give volume, they get organ edema and their cardiac output falls off because their cardiac function falls off from there. So keep that in mind. There is a second half to the Starling curve. In this particular slide, I just pretty much just for completeness sake, showing you the 4 phases of hemodynamic resuscitation. The rescue phase, which we do acutely, the optimization phase, which we do over a matter of hours, stabilization over days, and then the de-escalation phase where we try to get all that fluid that we gave the patient to resuscitate them and optimize them. We try to get it off and get the patient to stabilize from there. So, you guys read this in the back because I thought it was kind of funny. It says, unable to move from the spot, Trevor realizes that he buried the wrong nuts. Sorry. Sorry if that insults anybody, but it's his fault. He invited me. So when we talk about early goal-directed therapy, we talk about volume resuscitation, you know, it all falls back to this article that came out in New England Journal in 2001, where a group of guys at Henry Ford in Detroit got together and said, let's look at the difference on how we volume resuscitate our patients. So they looked at 263 patients that came into their emergency department, and they started the study in the ED. Patients were randomized into early goal-directed therapy versus control group. And to be eligible, they had to have sepsis criteria. They had to have 2 SIRS criteria and hypotension or lactate after they gave a fluid bolus. Now, the interesting about this that I liked is that it started within 1.4 hours after they hit the door to the ER. A lot of studies that you'll read, like the FACT trial, FACCT, looked at fluid boluses and fluid isonos in patients, and what they found was that liberal fluid was a bad thing. Restrictive fluid was a good thing. Well, if you look at the FACT trial weren't septic patients, they were ARDS patients. And in the FACT trial, they started fluid resuscitation at 24 hours. They started at 1.4. Again, read your abstracts to see if you're interested. Read your studies to see what actually happened. And they were looking at in-hospital mortality. Your early goal-directed therapy guys, they measured CVP, MAP, urinary output. They put a SCVO2 catheter in, measured SAT, measured hematocrit. Otherwise, standard therapy was just CVP, MAP, and urinary output. Now, I do know why CVP is in this study, because this data was collected in the late 1990s, and that's pretty much what we had back then. We were looking at PA pressures through PA catheters or looking at CVP from there. And what they found is that in the first 6 hours, which was done in the emergency department, in the ED, they found that the EGDT arm got more fluid. At hour 7, they were shifted to the ICU. In the ICU, the intensivists were blinded. They did not know which arm the patients were in. And at the end of 72 hours, what you found was that the patients actually had 103 cc's different between the 2 groups. So they made up a lot of fluid in the end. And what they found, all in all, 16% in-hospital mortality benefit with early goal-directed therapy, 60 days held out to a good 12.5%. But for years, we did that. It was like, oh, it's like the greatest thing in all. Look at this new study. And we were slamming catheters in, and we were following this particular algorithm until the guys up at UPMC said, wait a minute. We have another single study done at a single center saying that we should revolutionize how we practice medicine. And they're like, it doesn't make any sense. Early goal-directed therapy doesn't work. So these guys initiated what was called the process trial, where they repeated what Manny and the guys did up at Henry Ford, and they used 3 groups. They used the EGT arm, they used the standard arm, but they added a 3rd arm that they called usual care. And usual care was however the doc wanted to treat that particular patient. And as you can see from this particular slide, the groups were pretty much equal in most of the epidemiology. When you looked at the results, there really was no statistical difference in mortality between the 3 groups. Similar study that was done in Australia and New Zealand, the ARISE and ANZIX study. actually did very, very similar, and in that they just used the EGDT arm and the usual care. Again, epidemiology about the same, outcome, no difference in mortality. And then last but not least, the PROMISE trial done in England, same thing. Usual care, early goal-directed therapy, no difference in mortality from there. So based on that, these guys said that early goal-directed therapy doesn't work, and that we shouldn't be doing it. I disagree in that what you're looking at is by putting that usual care group in there, you have to remember that for a good 12 years, everybody's been trained on early goal-directed therapy. Everybody knows that early fluid optimization and standardizing your lactate and improving from anaerobic to aerobic metabolism was a plus. So when you look at usual care and you look at EGDT, what's the difference? Not much. So in my mind, should we call it early goal-directed therapy? Call it whatever you want. It revolutionized how we treated our severe sepsis patients, and it really changed how we practiced. And the numbers, since it does not show a difference in mortality, to me shows that EGDT works because it taught us how to do usual care. And that's how we treat our patients today. So I don't think there's a lot of argument for that. And I'm going to show you a study in a little bit that's going to actually make you kind of laugh. In 2015, CMS finally jumped on the bandwagon, and they gave us our sepsis core measure, which you guys are all seeing now, and you all know and love. And you have to, please guys, remember, if we have an abnormal lactate, you got to repeat it. You've got to show that you've checked a repeat lactate and that your lactate is improved, and you have to document it in the chart. You also have to document a physical exam or one of these at the bottom showing that you've optimized volume status. Otherwise, the ladies in like the 15th row or something like that will call you. So 4 years goes by. It is now 2016, and Sepsis 3 pops up. Now, with Sepsis 3, they wanted new definitions. They wanted to look at both sepsis and septic shock, and that's what we got. They said that basically we've used SIRS for too long. It's overly sensitive, not very specific, and why are we using sepsis and severe sepsis? Sepsis is a very critical disease process. We don't really need an adjective in front of it saying that it's severe. We know that sepsis is severe. So they looked at all of that in an article done by, whose name I cannot pronounce, we'll just call him Kersey, but he looked at it and said that basically, you're right. Utilizing SIRS, using 2 or more SIRS criteria, excludes a significant number of patients and includes a significant number of patients that don't have sepsis from there. A study done by Chirpek and his group also looked at the same thing and said, yeah, it's just not sensitive enough. I mean, if you look at the number of patients that are hospitalized who meet SIRS criteria, over half of them aren't septic. So why are we looking at this? So based on that, we took a look at it. Well, they took a look at it, I should say. It says, so how's your day going? This is a convertible in case you guys can't tell. So they looked at it, and Sepsis 3 came out. And in Sepsis 3, what they did was they dropped SIRS as part of the diagnosis for sepsis. They said it's more than an infection. It involves organ dysfunction, and therefore, since sepsis is a severe disease, we don't need the adjective severe anymore. So severe sepsis is gone. Much to my chagrin, I love that diagnosis, but it's gone. Now we have sepsis. Sepsis is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection and an increase in the SOFA score of at least 2 points. Now, when they looked at it, they thought, well, we've got SIRS, we've got SOFA, we've got LODS, we've got a lot of different scores that we could use. And they felt that by doing that, that the SOFA score was the best score for us. At the same time, in the same JAMA article, same JAMA magazine, at that time, they pulled up definitions for septic shock. And septic shock is now defined. It's a subset of sepsis. Sepsis now pretty much stands alone on its own. It's a profound circulatory, cellular, and metabolic abnormalities, and they're associated with a greater risk of mortality than sepsis alone after a patient has had adequate fluid resuscitation but needs vasopressors to maintain perfusion and their lactate is still greater than 2. So we now have sepsis and septic shock. Those are the two that we now have. And also, in the same edition, we had looking at different scores. Like I said, SIRS, they don't want to use anymore. So they looked at SOFA, they looked at LODS, and they looked at something they called quick SOFA score. And what they found was that by using the SOFA score and calculating that from respiration, coagulopathy, liver, cardiovascular, central nervous system, and renal, 0 to 4 points, calculating where a patient can get anywhere from 0 to 24 points, and the higher your SOFA score, obviously the sicker your patient is. They also took a look at it and go, well, that's a lot of stuff to do. Can't we do something really quickly as a screening exam? And they invented something called the quick SOFA, the Q-SOFA. Hypotension, altered mental status, tachypnea. Greater than 2 is suggestive of a patient who is at greater risk of developing sepsis and having a poor outcome. Now, when we look at ICU encounters, the quick SOFA score, not very good. When you look at out of the ICU, it's a very good source of looking for patients who are at risk that need to be looked at a little bit closer. Now, since we love lactate so much, and we all do, what happens if we add lactate to the Q-SOFA score? Nothing. It didn't improve anything for a quick exam. So that's why lactate was not involved in the Q-SOFA from there. So how do we figure it out? Patient comes in with a suspected infection, do a quick Q-SOFA on them. If it's greater than 2, look at them for organ dysfunction by doing a SOFA score. If it's high, they're septic. What's their volume status? Do they need vasopressors? What's their lactate? If the answer to that is yes, they have septic shock. If you're no anywhere in here, you just monitor the patient very closely from there. So it's a quick A to B to C from that particular standpoint. So, everybody still with me? Excellent. Thank you, Carlos. Now, once Sepsis 3 came out, it did not take long for the naysayers to start throwing barbs at this particular definition. And the biggest thing that these naysayers had was that this is not scientific. You know, where Sepsis 1 was based on looking at all these articles and pulling evidence-based medicine, Sepsis 3 was that of an expert opinion. So there's a lot of barbs being thrown back and forth. And the biggest controversy comes from SIRS versus SOFA. Back and forth, back and forth. You see it all the time with the limitations of the SOFA score, the limitation of SIRS, people going back and forth with it. Which one is better from that particular standpoint? So I'm still waiting. And the last one of these articles that I saw that just came out like a week ago was that we need more information, we need to look at it closer, and that hopefully we won't wait another 10 years to get Sepsis 4. Was the last thing that I read on that. This article came out by Williams. He agrees. Q-SOFA is good outside the ICU, not so good in the ICU, and they actually felt that Sepsis 2, looking at each of the different organ systems, although SIRS wasn't that great, but if you look at the different organs and the type of organ failure, is better than necessarily the SOFA score itself, and therefore maybe put the two together and recalibrate it from there. And here's kind of what they're showing you on the receiver operator curve between SIRS and SOFA from there. Study by Park and their group took a look in the emergency department. You've got your Q-SOFA score, your SIRS, but once again, you're outside the ICU. Outside the ICU, Q-SOFA is a great screening test from there, better than SIRS is itself. And so where are we now? Almost done, I promise. So where are we now? We're at Sepsis 3, right here. And next time I talk to you, it'll be like Sepsis 4 will be out there in 2020 because it'll be in 4 years. So looking at all of that, we have our definitions for sepsis. We have our Q-SOFA score. We have our definitions for septic shock. Now, in doing that, what impact has it made? When you compare Sepsis 3 to septic shock definitions from Sepsis 1, is it different? Well, what they looked at is retrospectively, they pulled the Jones article, which was lactate versus SCVO2, and they pulled the Puskarich article, which is early goal-directed therapy in the emergency department. There were 470 patients in both of these studies combined. And what they found was that 270 of them only met the definition for septic shock in sepsis 1. Remember, septic shock in sepsis 1, suspected or confirmed infection, two or more SIRS criteria, organ dysfunction, and that organ dysfunction was hypotension requiring vasopressors. Sepsis 3, remember the definition of septic shock for sepsis 3 was metabolic cellular cardiovascular failure with a high risk of mortality. 200 met that criteria. So if it met that criteria, it met sepsis 1. And what they looked at was difference in mortality. The difference in mortality for those who met just sepsis 3 was twice as high as those who met sepsis 1. Vasopressors about the same, length of stay about the same, ICU stay about the same. Their SOFA score was 9 for sepsis 3, and it was 4 for sepsis 1. And just in looking at that, what they got out of this article is, yeah, the people that didn't meet criteria for sepsis 1, that did meet for sepsis 3, they were sicker, and they're higher mortality. But what came out of the article, when you read the entire article, is that at the very end it says, hey, just because somebody didn't meet septic shock criteria for sepsis 3, they would have for sepsis 1, is that these people still had a high risk for organ dysfunction, and they still had a 14% mortality. So they were still really sick, and that you can't just rule them out because they didn't hit for sepsis 3 criteria. So it was a good point from there. This study just came out. Everybody's talking about it. I mean, you can't go anywhere, the coffee shop, the bookstore. I mean, people want to know, hey, are you using vitamin C for septic shock? I mean, I got a text just the other day going, hey, are you using vitamin C for text? I was like, are you kidding? I really got a text on that. What they did was they looked at retrospectively. They looked at 7 months before they started their study, and looked at 7 months with the study. In the treatment group, patients got 50 milligrams of hydrocortisone IV Q6 times 7 days or discharged from the ICU. Vitamin C, 150 milligrams IV Q6. Actually, that should be grams. I apologize. It's 1.5 grams. I apologize. That's a misprint. Q6 hours times 7 days or discharge. And thiamines 200 IV Q12 times 5 days. And what they looked at was mortality, PCT or procalcitonin clearance, vasopressor duration, and SOFA improvement. And what they found was really kind of interesting. 8.5% mortality with the vitamin C versus 40%. The 4 people that died did not die of sepsis. They died from something else. Kind of interesting. Your 72-hour procalcitonin clearance, 86.4% versus 34%. That's at 72 hours. Vasopressor duration, significantly different. SOFA improvement, significantly better. I don't know. Should we be giving vitamin C to all of our septic shock patients? I don't know the answer to that. Because again, if we go back to everything that we've learned from all the other studies, one and done didn't work. We had to repeat the studies and do it with a larger number. This was 47 people in each group. So it's kind of hard to say whether or not this is what we should be doing. Man, but the data doesn't lie. Those 47 that got it did pretty good. So it's something I think we need to talk about, more studies, and kind of go from there. When should we give fluid? Remember I told you, early goal-directed therapy doesn't work. Everybody's yelling and screaming, don't do early goal-directed therapy. Look at this study. It was just done. They looked at over 11,000 patients, and they looked at timing of fluid when they got volume resuscitated. And look at the difference in mortality between the early group and the late group. Patients did better. They did significantly better. If you want to look at it this way, early fluid, outcomes good. Late fluid, outcomes bad. Look at it another way. Early fluid, outcomes good. Late fluid, outcomes bad. You can't say early goal-directed therapy doesn't work. You can call it something else. You can do it, but just don't call it EGDT. People seem to get upset with you by that. And last but not least, folks, one of my favorite things besides lactate is procalcitonin, and we all know that. One of the biggest studies that came out was a pro-rata trial that actually looked at utilizing procalcitonin versus not using it. and they were looking at mortality and length of antibiotic usage, what they found was that there was no difference in mortality between using it, but a significant decrease in number of days on IV antibiotics in patients that you followed procalcitonins. What about the cost? Oh, you're ordering an extra blood test. Look at the cost difference. Statistically significant decrease in the use of procalcitonin in your patients versus those that you don't follow PCTs in. For those of you that are familiar with the ATS minor criteria for CAPS and the risk of patients needing invasive therapy, look what they found. Procalcitonin, much more predictive of who's going to need invasive therapy than those who don't. And this particular algorithm is awesome. Look at the difference in patients who had negative PCTs and negative ATSs versus those with positives, and the number of patients that ended up having to have invasive therapy from there. And then the Moses trial just came out. Everybody's talking about it. I'm telling you, if they're not talking about vitamin C, they're talking about Moses. And what they found was that if you can't clear your procal within 96 hours by 80% or more, your mortality rate doubles from 10 to 20% just based on procal. So with that, I'm done. I'll be glad to answer any questions. Otherwise, thanks for your attention, guys. And we are on time.